Good afternoon. Hi, I'm Andrew Jones of LKC Technologies. I'm here with Dr. Mike Cymbor. We're on the exhibit hall floor of the American Academy of Optometry meeting in Boston. We'd like to talk to you a little bit about electroretinography. So when you actually think about electroretinography, you probably think about what you learned in school and the large devices that you used, and how difficult it was for the patient and how difficult it is for the clinician. We'd like to talk to you today about the Retival. It's a handheld version of ERG that's very easy to use in the clinic. So let me get started. Like I said, I'm here with Dr. Mike Cymbor. Dr. Cymbor, can you tell us a little bit about your practice, where you practice, and the details?
Sure. I'm with Nittany Eye Associates in State College, Pennsylvania. We're in the backyard of Penn State. So we do a lot of disease. In particular, I'm kind of a glaucoma specialist. And so a large part of my practice is glaucoma, but we also see a lot of diabetic retinopathy as well.
Oh, great. Now, where are you using the Retival in your practice?
Yeah, so I'm using it on all of our glaucoma patients. We are a secondary referral center for glaucoma patients, and so I'm running the technology, the ERG technology, on all of my glaucoma patients. But now I'm also running it on many of our diabetic patients, particularly patients with diabetic retinopathy or patients who are at high risk of conversion to diabetic retinopathy.
And what are some of the challenges treating glaucoma and diabetes patients?
Yeah,
what are some of the challenges you face in both disease entities?
Yeah, in both disease entities, we're undergoing an evolution of our understanding of the diseases. And I think Fry's work in 2018 said it best, putting the coma in glaucoma. He really kind of made a good case in glaucoma that cells are not just alive or dead, the way we were all taught in optometry school, but there's this intermediate phase where the cells are sick. And if we can intervene at the right time and remove the stress from these cells, we can rehabilitate them and get them back into the healthy state. And I think we're understanding that about diabetes as well, more and more. And so I think those two pathologies, the challenge is, how can we make early diagnosis? How can we really test those cells to determine if they're stressed? And I think ERG technology fits in beautifully with those two pathologies.
Excellent. Next up, what type of protocols? The device has a lot of test protocols. What protocols do you use for glaucoma and diabetes?
Yeah, so let's start off with glaucoma. We run the photopic negative response protocol, and I run the long version that takes about a minute per eye, with setup and everything else, maybe 3 to 5 minutes, but a minute of actual testing time. So that's the protocol I run on all of my glaucoma patients. For diabetics, there's two protocols that I run. If I'm able to run the test prior to dilation, we'll run the diabetic retinopathy protocol, or the diabetes assessment protocol. If I see the patient and they're already dilated, then we run the Flicker 16 Trollin protocol. Because the first one, the diabetic assessment protocol, it really is dilation that you have to do it prior to dilation, because you really want to see how that pupil reacts. Whereas the other protocol, the Trollin protocol, they can already be dilated.
Okay. And what are you looking for in particular when you run those tests? What are some of the hallmarks or the data that you're looking for to help you with your diagnosis?
Yeah. So for glaucoma, I'm really looking at a couple of things. I'm looking at the time of the ganglion cell response and the strength of the ganglion cell response. And the time of ganglion cell response really fits in well to cells, to understanding their stress level. And the strength of the ERG response in the photopic negative response protocol is more for previous damage. So it's great to have those two metrics together to help understand glaucoma. With diabetes, I'm more. It's similar, but with the diabetic assessment protocol, there's 4 different metrics that we're looking at. Yeah. One is the time of the cell response. The second is the strength of the response. We're also looking to see how well the pupil responds, and then we're incorporating the patient's age into that. And then putting all of those things together, the instrument will give us a number. And longitudinal study, a big longitudinal study proved that if the number was 23.4 or higher, then there's about 11 more times of converting to needing a retinal treatment response for those patients. If it's under that number, much less chance of them converting to needing that type of treatment.
Great, thank you. How are you finding the Retival in terms of your patient flow, your office flow? Where do you fit it in?
Yeah, sure. So when we do visual fields, it takes it takes a significant amount of time. When we do other types of ERG technology, it takes a significant amount of time. The beauty in this instrument is both the portability and the speed of testing. So oftentimes in our glaucoma protocol, for example, we're able to do it, pretty much at many different stages, regardless of what room they're in, because it's not room dependent, because it's so portable. And I think probably that's a huge benefit, and the speed. So if in diabetics, a lot of times we're doing this test during their regular pretest, so we're able to to fit a couple of minutes in on those diabetic patients, particularly our high risk diabetic patients, during the standard pretest exam.
Now, how do your techs find using the Retival?
Yeah, so they really love it, actually. When I said, hey, we're bringing in a new ERG technology, they kind of groaned and said, okay, all right, it's going to take a long time, it's going to be difficult, there are going to be bottlenecks in the system. And I said, no, this is a little different. This is portable, and it's quick. And they said, okay, yeah, sure. I said, well, you be the judges. Well, you could run either test, and within a week of doing it, within a week of training, they all converted over to the RET eval.
Great. Well, thank you very much, Dr. Cymbor. I really appreciate your time today. Welcome, or thank you for joining us here. We have one more student session taking place later today, where we're going to do a live demo at 4 o'clock. But once again, I'd like to thank Dr. Cymbor for joining us. Thank you very much.
Happy to do it, Andy. I appreciate the opportunity.
Take care.